by Dr. ManojPrathapan. He will be discussing on glaucoma surgeries, the decision making.
A very good morning to one and all. At the outset, I thank Dr. Roshni for giving me this opportunity. I'll be talking on surgical decision making in glaucoma. There are some judgmental errors that we commonly make, and we have to keep this in mind before making decisions on glaucoma management. There could be disease-centric and patient-centric. So some of the disease-centric errors are, was it a missed angle closure? Are we doing an unnecessary trabeculectomy in a patient who could just be treated by a laser peripheral iridotomy? Was there a component of steroid response, and was steroid enough for treating this patient? Was the progression identified a true disease progression or just an artifact in our test? Is the field defect progression a fresh onset of neurological visual field defect rather than a glaucoma progression? Keep these in mind. When it comes to patient-centric errors, find out what is the expectation from the patient. Sometimes patient may push forward for a surgery because they may think that doing a surgery is to reverse the vision loss. Also understand the patient's economical status, the ability to follow up, the adherence and compliance of the patient, and patient's understanding of the disease and the need for continued management. Keep this in mind before making decisions for glaucoma. And this slide is straightforward. The common indications for surgery: medically uncontrolled glaucoma, progression of glaucoma in spite of adequate IOP control, intolerance to anti-glaucoma medication, or as an add-on procedure sometimes to phacosurgery. Let us go over some of the decision makings with case-based examples and literature reviews. This is a 55-year-old newly diagnosed mild to moderate glaucoma patient with 28 millimeters of mercury. What is the treatment advice? So a treatment naive patient, first time diagnosis, what should we do? Is it a trap or medication? All of us would agree that we start with the anti-glaucoma medication. So we have the CIGIT study, collaborative initial glaucoma treatment study. The aim was to determine whether with newly diagnosed open-angle glaucoma patients, they fared better with anti-glaucoma medications or trabeculectomy. It was a multicentric randomized controlled trial, and the recruitment happened during 93 to 97. About 607 patients were enrolled, and they were randomized to anti-glaucoma medications and trabeculectomy. The mean intraocular pressure after 5 years in the trap group was 14 to 15, and in the glaucoma medication group was 17 to 18 millimeters of mercury. The IOP reduced from baseline in trap by 46% and medication group by 38%. The results showed that the visual score was same in both the eyes. So there was no difference. One was not superior to the other. But the visual acuity loss was greater in the surgery group initially, that is the first 3 years, because of lenticular opacities that were developing. And once that was dealt with, they were similar. So the recommendation was there is no data to support altering the current treatment approach, which is medication. But mind you that they also gave another factor. The IOP fluctuation was a risk factor for progression in the initial medical therapy group. So keep that in mind when you follow up these patients on anti-glaucoma medications. Next case is a 55-year-old male with advanced POAG with intraocular pressure 21 on maximum AGMs. What is the next step? Since the IOP is 21 in the normal range, should we continue with the same medications or do a surgical intervention? So mind you, this patient is relatively young, 55 years, another 25 to 30 years ahead, advanced disease, so there is no tolerance for progression. So we have the advanced glaucoma intervention study. The recruitment period was from 1988 to 92. There were several reports that came in, and over 700 eyes were studied. They tried to compare two treatment algorithms. So that is not really relevant now because we don't usually do ALT anymore. But at age 7 report, they did this associative analysis of 6-year follow-up. They looked at percentage of visits with IOP less than 80 millimeters of mercury. The Shall we continue? Yeah. Okay. So these patients were categorized into 4 categories. So those who had percentage of visits with IOP less than 18 as 100%, 75 to 100%, 50 to 75%, and less than 50%. What they found was if the IOP was constantly throughout the visits, 100% of time, less than 18, they did not progress. But mind you, in that particular group, their average intraocular pressure was 12.8. And eyes which had 50% of times IOP more than 18, they did progress. So the lower the IOP, it is the better. So that is why we have this concept of target intraocular pressure. Being in the normal range is not enough. So this particular patient who cannot progress, who should not progress, with 21 pressures, we need to surgically intervene to reduce the pressures to target range. So target IOP is determined by the age of the patient, the initial intraocular pressure, the stage of the disease, the risk factors for progression, and other eye status. Next case. A 65-year-old male with unilateral neovascular glaucoma secondary to proliferative diabetic retinopathy and vitreous hemorrhage post-pars plana vitrectomy with post-anti-VEGF injection. Intraocular pressure 60. What is the surgery of choice next? Is it a tube or a trab? So we have the tube versus trab trial. About 212 patients were randomized into trabeculectomy and a barbell group. The inclusion criteria included patients who had prior cataract extraction or trab. And 81% of this population were having POAG. The 5-year results of TVT showed that both tube and trab did well over 5 years with IOP less than 50 millimeters of mercury. Trab group had higher failure rates. The take-home message, trab more likely to fail at 5 years. Trab had greater chance of reoperation and hypertony. Tube shunt has lower risk of serious complications. Trab achieved lower intraocular pressure with similar anti-glaucoma medication usage. Trab failure was higher, probably due to higher percentage of patients who had prior failed trabs, so 55% in the group. So the results were skewed against trab. So this particular patient who had prior ocular surgeries with neovascular glaucoma, tube would be the right way to go. Next case, 60-year-old male with POAG on maximum anti-glaucoma medication with intraocular pressure 18 with the progressive advanced disease. What is the best choice? Is it a tube or a trab? So here we have the primary tube versus trabeculectomy trial, or PTVT. They had 242 patients randomized to trab and barbelled. The inclusion criteria included the patients should not have undergone a prior ocular surgery. And 90% of the patients were POAG. The 3-year results of PTVT showed that both groups lowered intraocular pressure less than 15. The tube group had higher risk of failure. So the take-home points were at 3 years of tube surgeries have greater risk of failure, higher IOP, higher rate of reoperations, and greater need for medications. Tube shunt performed poorly at lower starting intraocular pressure. So coming back to our case, this particular patient who was conjunctiva, good conjunctiva, primary surgery, the best choice or gold standard is currently trabeculectomy. Next case is 65-year-old male with unilateral neovascular glaucoma. We discussed this patient earlier and we found that tube is the way to go and not trab. So out of the tubes, which is the best choice? We have the Ahmed-Barbell comparison or ABC study. The aim was to compare the efficacy of Ahmed versus Barbelled in treatment of patients with previous intraocular surgeries and IOP more than 80 millimeters or refractory glaucomas. It was a multicentric randomized control trial. 276 patients were enrolled in the study. Patients in AGV group had lower intraocular pressure in the initial few weeks as compared to Barbelled, which was expected. Patients in the Barbell group had lower IOP compared to AGV group after 1 month. This is because in the initial period, we ligate the tube in Barbelled to prevent immediate hypertony. Patients with Barbell glaucoma implant group required less topical ocular medications as compared to AGV at 3 years. So the failure rates were almost similar and serious complications were also similar in both the groups. Next, we have an ABV study, Ahmed versus Barbell study. This was a very similar study to the earlier study, and the results were also pretty similar. The pool data from both the groups, when we analyze, about 50% of them had POAG, 29% had NVG, and 9% had UAT glaucoma, and 7% had PSCG. Barbell achieved lower intraocular pressures, 5-year control good in both the groups, and 0.5 medicines less in Barbell group. So the take-home message was Barbell implant had better success, lower IOP, lower anti-glaucoma medication, but higher hypertony. In NVG, Barbell had higher proportion of patients with PL minus vision. This probably is because NVG being a very aggressive disease, the initial time period where the pressures are very high may be the reason, or maybe because when the tube opens, there is an immediate hypertony that happens, which takes a few days to recover. This could be the reason why there is a poorer visual outcome in those patients. So in our particular patient who is having NVG with PDR, post-surgery PPV, the better choice could be Ahmed. It is slightly more safer than Barwelt, but we can still go for Barwelt with supramed suture in situ during surgery. Thank you.